So it seems to be all about the money sometimes. So diagnostics can be fairly expensive, and diagnostic fees go up, and the cost of pigs certainly goes up, especially the older the pig, the more expensive it is to sacrifice it for a necropsy. And so all your veterinary expenses are always under scrutiny. And so it's really an investment of your time and effort goes into all the decisions we make as veterinarians, and that includes your medications, which is the most tangible cost, and vaccination. But timing of pig movements, if pigs are held, that's expensive. And then your diagnostic submission. So those seem to be a great big bill when you get it, but probably in the grand scheme of things, it's smaller. And so you have all these different costs of contributing to diagnostics, and then let's say you invested all that money and your results don't even make sense. What do you do then? So what I'm going to talk about today is basically steps to improve your diagnostic value. And a lot of that really, it's not rocket science, to quote somebody, but it's a lot of proper sample technique and finding those pigs. Submission of samples, and then how to interpret the results. Overinterpretation or misinterpretation can be very costly as well. So the keys to diagnostic success, your goal with any diagnosis is to accurately and timely diagnosis of disease, and this will hopefully decrease losses in whatever way they're occurring. So if it's losses due to failure to gain weight, physical losses as in the pigs are dying, or monetary losses, you can't sell the pigs to the right market, that would be difficult. And also to facilitate therapy, we like to think that we do the diagnosis so that we use the right drug or intervention a lot of the time. And eventually, or essentially, we're protecting the customer, and whether that's the customer, the food consumer, or if it's a downstream customer, somebody buying your pigs. That's the goal of diagnostics. You want an accurately and timely diagnosis of that disease. But specimen selection and quality greatly impact the diagnostician's ability to accurately find the cause of death or disease for you. And that can happen in a number of different ways. And I'll interject some fun things. So how do you get there? How do you get that accurate and timely diagnosis? Well, you do a proper disease investigation. And to start that disease investigation, you need to figure out why are you doing it in the first place? Is there clinical signs? That's the most obvious thing. Hey, doc, the pigs are coughing, come out. Hey, doc, the pigs have diarrhea, come out. Sometimes you're called to a farm because they received unexpected or undesired serology results or slaughter check findings, if anybody does slaughter checks anymore. Does anybody do slaughter checks anymore? No? Yeah, okay, there we go. So that's good to know. And so since a lot of the farms collect their own quarterly sera or monthly sera, you may not even have known that it had happened, but they get a positive, they don't understand, you have to go out to the farm. And maybe there's a change in production, where maybe they want to mix flows or mix pigs, and maybe food has changed. A double stocking certainly is a big production change that can cause a lot of clinical signs and problems for a herd if it's not done right. So you need to be prepared to do a disease investigation, and you need to be able to select pigs. And to be prepared, you need to have the time to do it. So this isn't something you can do at the end of the day, or if you've got appointments stacked on top of each other. I would say the number one thing you need to have with you, one of the number one things you need to have with you would be a thermometer, and this is to identify febrile animals. And we'll go through a case of where the thermometer really helped the diagnosis this time. Clinical observations, you have to take the time to do that, and that's more than just walking through the pen. It's actually stopping and sitting down into the pen or leaning against the fence or whatever, but just watching them. Euthanizing pigs versus sampling dead pigs is very important. There's a variety of reasons to do that. Euthanized pigs, the pathogens then are still alive. There's a lot of fastidious pathogens like Haemophilus parasuis that don't survive well in postmortem tissues. So depending on the disease you're going after, you'd rather euthanize a pig. But that's pretty difficult talk to have with a producer. Let me kill this pig for my purposes, when there's piles of dead pigs that they think that you could open. And then treated versus untreated pigs. Certainly treated won't affect a virus diagnosis, but treated with antibiotics will affect a bacterial diagnosis. And amazingly, we can tell the difference in tissues from pigs, from treated or untreated pigs. When the bacteriologists streak out the plate of the lung sample or whatever, they'll often ask me, was this pig treated? So they can tell the difference in the growth rate and the type of bacteria. So to do a proper necropsy as part of this diagnostic disease investigation, you need to have the right tools. And there's a lot of people that would brag that all I need is this one knife, or I used my Swiss Army knife all this years in a row and this is all I've ever needed. Well, yeah, you need a sharp knife. So find that knife and protect it with your life, and don't let anybody else use it to do stupid things with it. I need assistance and assistance when I do necropsies. I'm not physically strong enough to move the pigs. Once I have the pig, I can usually manipulate a lot of the legs and tissues and heads and stuff myself. But it's nice to have an assistant, either just to record your findings or to physically do some of the work. Have a euthanasia method that's tried and true. It's very unfortunate to go to a farm and see a pig that needs to be euthanized for animal welfare reasons and not having a way to do it. So have a method that works for you, that's accepted and approved. And work in a good environment. Certainly you don't want to open up a diseased pig in a healthy pen. You don't want to do it in the blazing hot sun. You don't want to do it in the freezing cold. So find a place that works for you to do your necropsy. And then begin. And these are all things that you can scout out ahead of time. So just jumping into some lesions here. This is the 60%, I would say. 60% of our submissions are respiratory disease submissions to the diagnostic laboratory. And if you look at NOM surveys, 70% of the complaints are due to respiratory disease complaints. So respiratory disease submissions you should get really good at, because you're going to be right about 70% of the time, or you can handle it 70% of the time. And generally, your tissue sets for a respiratory disease, and I'm moving into specific disease entities now, is going to be lung tissue. I mean, if you just submit lung, you're doing a pretty good job there. You should be able to diagnose about 60% of the respiratory problems based on lung. But do not forget that the respiratory tract is connected. It goes from the snout through the turbinates, tonsils, trachea, and lungs. And so you'll want to collect those things. Now, snout can be difficult to collect. On the smaller things, you can submit the snout as part of the head, and we'll get the tonsils as well, and the brain, and things like that. Or you can saw that off with a good saw. But snouts are very important for probably undiagnosed respiratory disease, because the respiratory disease may start in the turbinates. Tonsil is an excellent organ. I would like everybody to remember that and find it and submit it every time. Not only can we do a lot of foreign animal disease surveillance for the United States, such as classical swine fever, but there's also bacteria that are harbored in the tonsil, such as Actinobacillus suis and Actinobacillus pleuropneumoniae, that we may miss the lung lesion, but they may be harboring in the tonsil. And certainly respiratory tract infections are often part of systemic diseases, and that's why we ask for liver, spleen, kidney, and lymph node. Serum is also important to collect, and that's why euthanizing pigs and collecting the serum, or collecting serum and then tissues from dead pigs are also good, and I'll have a case example of why that's good. This is a big thing, so quantity of specimens, and I've worked with a few new graduates that got stuck out into production systems all by themselves, and they often send samples more is better. So I'd get the entire small intestinal tract in a Whirlpack bag, or and then oozing out of the bag, of course. So more is not definitely better, but you do want to be generous with your samples. And we're in Minnesota, and so I'm going to say that your fresh tissue should be the size of a hockey puck. If you're from the southern part of the United States, your fresh tissue should be the size of a tin of tobacco. And if you have neither of those vices, it should be the size of the palm of your hand. So you can carry that with you always, your hands. Always include airways when you submit the lung. Don't just cut the tips off. We want a good section of a bronchiole or bronchus, because Mycoplasma pneumoniae only lives in the cilia on that bronchiole, okay? That's where it is the most. Of course, it travels around and things like that. But airways are essential for diagnosis. So not just tips of lungs. Go through a section of lung. And if you submit something as big as the palm of your hand, you'll certainly get an airway in there. When we're talking about intestines, you don't need to fill the gallon Ziploc bag with the entire small intestinal tract, but 12 to 15 centimeters of intestine is good. And the most important thing is to remember that lesions are multiple and segmental. And so you're fairly lucky on a systemic disease that it's all over the pig, but usually the lesions are only in portions of the tract and not throughout the whole entire organ. So you want to sample several different areas. If it looks different from the other section, sample it. So for example, the left lung lobe may look different from the right. You should take a sample from each. So here's an example of a lung, and it has some patchy pneumonia here. And certainly you'd want to sample from all these different areas. This is the apical lung lobe. That's also very good. The middle lung lobe will receive a lot of the pathogens. If you just send this lower tip, I'll miss some airways. I won't be able to diagnose mycoplasma. I'll tell you that I tried, but I bet you I'd miss it if you just sent the tips of these lungs. So you want to sample multiple places through a lung. And here's an example of an excellent submission. Here's our lung over here, big generous portion. Here's our metric here of 3 centimeters, big generous portion of lung. And why do we need generous portions of lungs? I don't know if you've spent any time in the bacteriology lab, but they actually sear the outside of the tissues. So it'll cook your sample if it's too small. So they actually heat up a spatula, sear it, cut it open, and sample the inside. Nice section of trachea. Here's the jejunum with a mesenteric lymph node, another mesenteric lymph node here, little piece of spleen, little piece of liver. Little being it's greater than 3 centimeters, right? So excellent submission for a respiratory disease or a general tissue set there. Back into quantity of sample, this is where, a lot of us base our diagnosis just on PCR or serology results, and this isn't just a plea for me to continue my job as a pathologist, but histopathology is really important, and our case example will show that. And to properly fix tissues, they need to be thin. They need to be less than 1 centimeter thick and less than 5 centimeters long. And remember, lesions are multiple and segmental. This is the second time I've said this, so it's probably important. And so you want to send in different sections of intestine. Dr. Kurt Rosso, a diagnostician at the Veterinary Diagnostic Lab at the University of Minnesota, he looks at 9 sections of jejunum every time. I look at 4. He looks at 4 pieces of lung every time. I look at 3. So when we have a pig ourselves, that's what we're collecting. So if you have trouble making a diagnosis or getting a diagnosis that makes sense, go back to your multiple and segmental thought. And remember, I have to section multiple sections of intestine or multiple sections of lung. Don't flush out the intestines. The contents are important. We can see bacteria in there. They're attaching, they're effacing. There's parasites. Things like that. What the pig is eating sometimes is in there. When you're submitting fixed brain, you don't have to do much to it. A brain is a magical organ, which is what I say to my mother. So my mother was lamenting the other day and giving me some information. This is a sidebar to keep you interested here. So my mother was saying, I need you to pray for your cousin Bill today. He had a seizure, so we hope that his brain cancer isn't back and that it's just that he forgot his medications. I said, well, that's a good thing to pray for, Mom. I'll do that. So I called her the next day and she said, well, it was just that he forgot his medications. There's no recurrence of the brain cancer. And he just forgot his medications. And I don't know why that would happen to him, that he would forget his seizure medications to have a seizure the next day. And I said, well, Mom, there's the newer generations of anti-seizure meds, they don't last as long in the body, and if you miss them, you'll have a seizure. Well, if I miss my Prilosec, I don't get heartburn every day. So I had to explain to her how the brain was a magical organ, Mother, and it's different than your stomach. And so the brain is a magical organ. That's the moral of that story. And that you can fix it as is. A half of the brain will fix just fine in formalin because the formalin can actually permeate the brain tissue. Formalin cannot permeate half of a liver. It's too dense of an organ. So brain is magical. Send in at least half and it'll preserve in the formalin just fine. Use buffered formalin, and I don't know if anybody remembers why this is because if you use unbuffered formalin, you get precipitates on the tissue and it looks like somebody sprinkled salt and pepper all over our slides and we can't see through the precipitates. And the formalin to tissue ratio should be 10:1, and that's a lot of formalin. And so one thing you can do to get that proper ratio is to fix those tissues overnight in your clinic, then pour off the tissues and send us the fixed tissue with just a little bit of formalin to keep the samples wet if you want to hold them overnight and not send the volume of formalin through the mail. And that works really well. These are our histopathology cassettes. They're 3 centimeters by 1 centimeter, and so your sections then are trimmed into these smaller cassettes. And so if you send fixed tissues that are 1 centimeter by 3 centimeters, they'll fix just fine, and then we'll cut them down further to fit in these cassettes. These are the size of a pack of, or a piece of bazooka gum, if I'm dating myself there, if anybody knows bazooka gum. Nobody? Anybody? Quince? More irrelevant things? All right. This is that multiple and segmental that I was talking about. So the circles here represent portions of lung that I would like to receive as fresh samples from this lung. And then sections of the rectangles are sections that you could take for histopathology going through the lesions. But we want those consolidated areas because that's where the pathogens settle out into the lungs. So now you've done all the work, you've collected samples. Now how are you going to get them to the laboratory? You can drive them in, which is nice, but the laboratories are usually far away. So refrigerate your tissues, never freeze them. You can refrigerate if you have to the unfixed tissues. Don't ever freeze formalin-fixed tissues, it just blows them apart. And then submit them with frozen gel packs. And the amount of frozen gel packs you need should equal the weight of the tissue you're sending in. So if you have 6 pounds of tissues, you need 6 pounds of frozen gel packs. And that's going to be a 12-pound package that you're going to mail in, which is very expensive. But if you do some strategic sampling and you collect the right size samples, you should be able to minimize that. Roll pack bags are very nice for unfixed tissues, but sealed containers are better for formalin-fixed tissues. Your roll pack bags, they all leak eventually. Okay, they're either not spun enough down or they're filled too high, but they all leak. And all Ziploc bags eventually leak. So don't overfill bags. Sealed containers are better. This is an excellent example of a diagnostic set. Notice it's from 1983. So we haven't seen a good diagnostic set like this for a few years. No, I'm just kidding. So swabs, cecal contents, fixed sections of jejunum and colon, fresh, refrigerated, some smears. Who does that anymore? That's awesome. And then serum already spun down and separated from the clot. That's just whoever that was. Case 6828 from 1983. They need an award right there. And then we know what the organs are. You don't have to label them for us. You do need to label swabs. All right, there's a huge difference between the bacteria that'll be in a rectal swab versus the bacteria that'll be in a pericardial swab. And you'll waste a lot of laboratory resources and time if you don't label swabs, because we'll nurse colony every swab we get thinking this could be a pericardial swab. We need to get Haemophilus parasuis. We need to do a nurse colony of strep so we can get, or of staph so we can get the Haemophilus parasuis to grow. Well, if it was a rectal swab, that was a complete waste of time. So please label your swabs. And I don't know who he is, but Brian, he gets a lot of swabs submitted. There's Brian swabs coming in every day to the lab, which is actually brain. There's another joke. See how it works? But name it. And heart, it's fine. So you do need to label your swabs. You do not need to label your tissues. We're fairly confident we can recognize liver and spleen. Although if you do send in tubular organs, those are nice to label. Uterus is difficult to tell from stomach sometimes. And then cecum, if it's devoid of material, can be difficult to tell. So do label your tubular organs, urinary bladder, uterus, and if you're concerned about a particular lymph node, tell us where you collected it from. So tubular organs and swabs need to be labeled, especially the odd ones. All right. A little more about swabs. They're an essential diagnostic tool, and why they are essential is because they allow you to transport the fastidious organisms to the lab to increase your chance of detection. Haemophilus parasuis does not live well in postmortem samples. It needs that transport media to survive the trip to the laboratory. Same thing with influenza virus. A little liquid Stewart's media or phosphate buffered saline allows that transportation of that organism to the lab. The swab also allows you to gain access to sites that may be difficult to open. So you can go through the foramen magnum and sample the brain. with a swab, and you don't need to open up the cranium and get through the skull. It allows you to sample things quickly with decreased contamination from your knife or your hands. And this is where your assistants come in. So if you've handled the pig and you've dragged him and now you've got manure on everything and you've accidentally nicked the colon, you've got some dirty hands. But how wonderful it is for that vet student that's standing next to you or the farm staff. You can say, take this and swab it right here, and you can localize the lesion, and they can swab it and it'll be decreased. And that same person with the clean hands then can recap that swab and label it for you. So swabs are an essential diagnostic tool. Now the appropriate swabs to use are synthetic swabs. And there's this whole thing about cotton versus synthetic, and I don't even think anybody makes cotton swabs unless you're doing ear cleanings at the clinic on dogs and cats. But basically all the diagnostic swabs are synthetic. They're usually Dacron or rayon, and they're on plastic shafts. And the plastic shafts are rigid. Most of our pigs, we don't need to use the flexible aluminum samples, especially on a post-mortem sample. The type of media can vary on these swabs. Most commonly, the swabs have a liquid Stewart's or a Hanks media. It's usually liquid Stewart's, but be really careful to avoid any agar gel tape media unless you're going after a specific microbe and you're working with a researcher and they say you need to use this media, it's the best ever. But the reason why agar gel type media for swabs is bad is they've shown in human microbiology laboratories that they can have inhibition of PCR by the agar from the transport media from calcium alginate tip swabs. And so they're missing a lot of diagnosis there by PCR. This is on our website, but one inexpensive multi-purpose swab, we've used it in the laboratory for 13 years or more, is by Becton Dickinson. It's the BBL culture swab liquid Stewart. And that's the product number, and it comes in packages of 50. These swabs do have expiration dates. It's the media that expires. And so just kind of calculate how much you'll need each year, and don't use expired ones if you can avoid it. Just an example of some sealed containers. You can actually buy formalin, nutrient buffered formalin on the right there, but these sealed containers. And then these then again go into secondary containment to contain any leaks. These are rigid, they could break, and they could freeze and crack too, but they are much better for liquid specimens than bags by themselves. I already said this, all well-packed bags will leak, and it's usually because they're improperly closed or overfilled. So practice your whirling techniques. Leaking formalin, who cares? Well, it kills the bacteria, and you get culture negative. It kills viruses, and you get culture negative. Usually PCRs still work if you have leaked formalin all over everything. But leaking formalin, one of the things that'll cause your package to be rerouted or discarded or set aside by the courier, and they'll label it hazardous waste, and they'll submit it to us in bags and off hours by the manager. And so that's the other thing about leaky formalin. All right, so now you've done all this stuff with the specimens, and now it's an outer bag, and you want to label it, and you want to protect. That's because you want to protect your shipping container from the feces, formalin, whatever's inside that bag. And then your submission form goes outside of the cooler, between the cooler and the cardboard box. Make it obvious, like we open it, we see the submission form first thing. And you went through all this expense, and you ordered the special swabs and things like that. So send it same day or overnight delivery. One of my favorite, and I haven't vomited at work since I was a resident. And 2 years ago, it was July, and somebody was doing a lameness workup. And one of my things about lameness workups is if you can afford it, send the entire leg, and I'll dissect it. I'll send the joints. If you put enough ice packs with that leg, it'll be preserved just fine. The organisms will be fine inside the joint. I'll dissect it with a scalpel blade, get all the anatomy stuff that we need. That's fine. Well, somebody decided to ship me the legs. Well, they were finisher pigs, so they're pretty big legs. They did not send enough formalin, and they shipped it ground transportation. So 5 days later in July, I had a package of unrefrigerated ham hocks, basically. And that was the one that did it after 10 years of diagnostics. So July legs that are unrefrigerated don't make it. So make the effort to do same day or overnight delivery on that package. This is just a picture of the packages we receive. We get supplies and specimens delivered, and we unpack them. And that's just one of the many carts that'll come in. So you need to make your submission clearly identified as to who it's from and what samples are in there, because we've got a lot of them to go through. And these guys are opening them up and sorting them out to the right laboratory. Serum goes to one lab, tissue goes to another, bac-T samples go to bac-T. So you need to make it pretty clear. These are rectal swabs for culture. These are oral fluids for PRRS, and PRRS PCR versus PRRS ELISA. Because there's 300 of these coming in and you want yours to be routed properly. All right, so that's a little bit about essential specimen collection and submission. And why all that matters, Dr. Rebecca Davies, who's our quality coordinator at our laboratory, keeps us accredited, keeps us online, presented a lot of nice things on sample handling and why it's expensive. So this is examples and reasons for laboratory errors. And it's nice, this is not a total CYI, it's not my fault presentation. This is a way to link it up from the clinic to the laboratory. So here's our beautiful laboratory. All of us want to get it right the first time. We want to make that diagnosis, have it right, have a high degree of accuracy, and have a minimal number of errors. That's probably the goal of life, really. But the errors do exist in laboratory medicine. There's a famous case here in St. Paul in the human hospitals where they mixed up biopsies and told one woman she had cancer and that woman she didn't. They actually had them mixed up. And that's because they got their slides and they got all 20 cases in one flat. And now they submit one case per flat or one case per file folder ever since then. Because there's humans that are reading these samples, and there's humans working in the labs, there's humans working in the farms. There's errors in laboratory medicine, and the interval between the time a sample is collected until the result is reported to the veterinarian can be divided into 3 phases if we think about where do errors occur. The pre-analytical phase, which would be at the farm or the vet clinic, the analytical phase, which is at the laboratory, and then the post-analytical phase is the reporting of the results. So let's look at those. So errors in laboratory medicine, again at these 3 sections. Now who's responsible for this one? Well, the pre-analytical phase is primarily the responsibility of the submitter. It's either happening at the farm or it's happening at the vet clinic. The analytical phase, that's the responsibility of the laboratory. And of course, what happens in the pre-analytical phase can directly impact the analytical phase. But the post-analytical phase, that's a shared responsibility. When you're accessing your results, what are you doing with those results? Are you reading them appropriately? Is it a competitive ELISA, negative values reported, positive values, etc.? So the analytical phase error, I skipped a slide. Pre-analytical phase errors, what those consist of are animal status and information sharing. Which animal has exhibiting clinical signs, I'm writing that down. Animal 1 had pericarditis, animal 2 had diarrhea, but then when we get the samples into the laboratory, animal 2 is the one with fibrin and animal 1 doesn't have any intestines or something like that. So animal status, specimen collection, all the stuff we've already talked about, specimen processing, specimen transport, sending those samples the right way, overnight or direct courier, things like that. And then our delivery of that to our individual laboratory sections. So if you just write, I want PRRS on this, well, there's a PCR laboratory that detects PRRS, and there's a serology laboratory that detects antibodies to PRRS. So delivery of it to the right laboratory for analysis. Analytical phase errors, those that occur in the labs, are all the steps involved in the actual analysis of the sample in the lab. So examples of lab errors that occur are mispipetting. So you've got 90 samples lined up and you put sample 1 into the well for sample 2, etc. That's be a mispipetting. Fibrin interference from clotted samples. Equipment errors, if the power goes out or it's not calibrated. Tube order errors. If you ordered your tubes left to right and we put them in the order right to left, 1 through 10 versus A through Z, for example. And transcription errors. This is pig 444 and this is pig 4444. That could be different things with transcription. And those analytical phase errors, those have been greatly reduced because of quality assurance and quality control programs that are in place that are necessary for accreditation. So when there's lack of sufficient quality control or protocols, then you get analytical phase errors. There's assays that will interfere with each other. And for one thing for that is that the spinning time, for example, for a swab for mycoplasma is different from the spinning/centrifugation time for influenza. So if we processed a swab for mycoplasma and then you want to add influenza later, it might not be able to be done based on how we handled the swab. So we figure out those assay interferences, trying to think of how many samples can we do, how many tests can we do off the right swab. Lack of validated assays. I just had a conversation in the hallway. Can somebody send me FTA cards? These are cards of paper that you spot serum or oral fluids or lung onto and test for certain pathogens. Well, I haven't validated every sample on an FTA card, so I don't know if that would work. And then inappropriate method choice. You wanted to see if the samples were positive for mycoplasma and you requested culture for a lung. Well, we don't really grow mycoplasma very well. It's a fastidious organism. It requires special media. So if you're relying on culture to diagnose mycoplasma, for example, that would be inappropriate. And the same things happens for us. If we're looking for selenium levels, selenium is more accurately done on blood, but what if we only have plasma or serum? So inappropriate method choice, serum selenium versus blood selenium, for example. And then we're into the post-analytical phase errors, and these happen more and more when things are reported right to the farm sometimes, and they're reviewing the results, and they don't know what a positive means, or when we bleed 100 pigs and one of them is positive for PRRS virus antibodies by ELISA, and they think they need to tank the whole group, and they don't understand sensitivity and specificity of a test. So post-analytical phase errors occur, and so we have to review the results for discordance. Is this what I sent in? I thought I sent in 10 samples. You're reporting results out for 20. Sometimes we repeat results. Sometimes we have a multiplex test and you're saying I only requested TGE, but you're reporting PED results. That's because our TGE and our PED are multiplex. They're done together at the same time on the same results. So how you interpret and utilize those results. So you certainly don't want farm staff to call a group of pigs because there's one PRRS ELISA positive out of 100 in a group on serology tests. A lot of times there's no reference intervals, and this is a good example, would be pig serum iron or pig liver iron results. A lot of the laboratory reference values available don't account for our new iron medications that we give the pigs, and so you have to know when the iron shots were given in order to interpret a liver iron level for a pig. And then post-analytical phase error, something that can occur is if the sample was stored at a different method and then you want it retrieved for another result. For example, all of our fresh tissues that we receive for bacterial culture are then stored at 4 degrees Celsius, so just refrigerated for 2 weeks. And certainly things like influenza and PRRS can degrade over time at 4 degrees Celsius. And so you may ask for a sample to be resurrected from the refrigerator and tested for PRRS or flu, but the pathogen may have degraded in that time. So sample storage can affect the post-analytical phase as well. So if we're looking at those categories, again, pre-analytical is the clinic and the laboratory. We could route something inappropriately based on the paperwork, but something could be requested wrong or submitted wrong. And so we often get cases, phone calls that says, you know, hey, I submitted this case, it was from Farm A, but it's actually from Farm B, so could you change the name to Farm B? Things like that. So there's pre-analytical errors as well. Analytical errors are primary at the laboratory, and post-analytical errors, that's another shared responsibility there. So how to get over those pre-analytical errors. There's some sample handling hoops that you have to go through. One of them is sample labeling. What I say when you're going out, especially to collect a lot of samples, is to come out with your tubes already pre-labeled consecutively 1 through 100 or 101 through 200, whatever, but have those tubes already labeled. And that's a step that you don't have to spend at the farm. or after the farm. And then you can just record on a sheet of paper as you're bleeding with your assistant, because I have these magical assistants that follow me everywhere, that tube 1 is for pig 444 and tube 2 is for pig 3. And that just goes on a sheet of paper that you can submit directly to the laboratory if it's clean and clear enough, or transcribe again later. Tube type is very important. This is more for serum and things like that. There used to be a discussion that the Corvax serum separator tubes caused false positives because the gel would separate and cause false positive perizalizo. That hasn't been verified at all. But certainly if we're requested to have whole blood and you submit tubes in a clot tube or a red top tube, that's not going to be whole blood. That serum is going to separate out and the tube is going to clot. So tube type affects it. Tube fill level, don't overfill the tubes because they'll leak, and and especially for a Corvax serum separator tube, you need to submit blood over the wax level there to separate that out properly. Storage time and temperature. Certainly if you leave things on the dashboard of the truck, things can degrade. Transport time and temperature, the example of the legs that went on ground couriers, and then how they are when they finally get to the lab. All that stuff affects the condition of the sample when it gets to the lab. Some example of how to overcome animal status and information sharing errors. These are some clinical examples of an error and what it impacted is. So if you had a reason for a submission is diarrhea and you put the age of the pig as 3 and you sent us feces, this is a number of things that could be done on that depending on the person. We don't know the age of this pig and we only have feces, so I don't have a diameter or a length of intestine or size to go on either. So this pig could be 3 days, 3 weeks, 3 months, or 3 years. If it was a 3-day-old pig, I have a lot different differentials than I do for a 3-year-old pig. Certainly rotavirus, TG, PED, Salmonella, E. coli, the Clostridiums become very important for 3-day-old pigs. Not so much for 3-week-old pigs, and now we've got protozoan parasites, such as coccidia, to look for, and the aerobic bacteria, such as E. coli. A 3-year-old pig, now we're getting into Lawsonia, Yersinia, metazoan parasites, Brachyspiras, Salmonellas, and so you can see the different sample handling that we do of a feces based on the age of the pig. So age of the pig is very, very important. 3 days, 3 weeks, 3 months, 3 years. We really need to know the units there. So please put the age of the pig. Reason for submission, here's an example. Pale pigs, and the age of the pig was 2 weeks, but the sample, we don't know what it is, or they don't know what to submit. If you're going after Mycoplasma haemosuus, for example, as an infection in a pig and a cause of anemia in piglets, which could lead to pale pigs, and if you submitted whole blood in EDTA, then we could do Mycoplasma haemosuus detection by PCR, and that requires a purple top tube. If you submitted serum, then we can do Mycoplasma haemosuus antibody detection, but you can't do a PCR test. You need those red blood cells to do the PCR. And the other thing, if you only submitted serum from an anemic pig, we could do the antibody test for Mycoplasma haemosuus, but it's not interpretable for baby pigs because it may be maternal antibodies. And it may also be false negative because antibody production to Mycoplasma haemosuus occurs in waves. So the only thing you can do a serum for a pale pig is maybe a protein to see if it's a protein-losing anemia. But really, you need whole blood for Mycoplasma haemosuus. Some examples of how the specimen handling and sample handling can lead to errors. If we centrifuge things at high speeds for long times at high temperatures, we'll destroy viral RNA, making it undetectable by PCR. And that can happen in the laboratory as well. I remember buying old centrifuges, from old labs, and then they'd have to run in the refrigerator so they wouldn't overheat the samples while they're spinning in the clinic. If you accidentally freeze formalin-fixed tissues, that leads to freeze-thaw artifacts, and that destroys the tissue integrity, so we are not able to analyze the cells to look for inclusion bodies or necrosis or anything. It just destroys it. Improper insulation and refrigeration of tissues or serum leads to high temperatures, and that destroys the pathogen and promotes decomposition, destroys the RNA and DNA. That makes it even unsuitable for PCR. So examples of some temperature things. A long time ago, we took some serum and we determined the viral RNA quantity over time, which is the x-axis, and the quantity is the y-axis. And that was at 4 degrees or at 25 degrees. So PRRS and serum relatively stable over time, regardless of the temperature here, but we do have a significant drop-off that occurs regardless of the temperature within a day. So 24 hours after collection, we have still positive. Our cutoff here is the red line. Our cutoff here is the red line. So we're able to detect PRRS every day. But this is one of the reasons why people drive samples up to the lab versus shipping them overnight. Still detectable, but we've had a great degrade in RNA over 24 hours and relatively stable after that. Here's flu at different temperatures, 37, which is body temperature, 25, which is room temperature, and 4 degrees Celsius, which is refrigerated. Certainly the quantity of RNA remains the same over time if it's refrigerated. Flu's a nice stable bug. And it decreases over time at room temperature. And then at body temperature, it goes to almost undetectable for a while. So different pathogens survive at different rates. Then there's analytical phase errors, and these are the things that after we report the results. So we have this new thing in the laboratory now that we have to approve the results of our pathology reports. This is the stuff where I write the histopath and make the diagnosis. Have to hit an approve button before you can see that on the web. And what that's led to is I forget to approve the results and people think that I didn't do their report. So there's a laboratory error on our end of not sharing the data. But there's all sorts of steps involved in the actual analysis of the sample in the laboratory. So our analytical phase errors, again, mispipetting and fibrin interference and things like that. Yes, these are duplicates. All right, so which errors recur with the greatest frequency? What do you think? Is it your fault or my fault? Or is it our fault? Is it a shared responsibility? Well, let's look at the literature. The humans like to throw each other under the bus more than we do. So a 2002 article evaluated 8 years of literature from Medline and hand searches of the literature based on, they searched for the words mistakes, blunders, errors, problem, or defect associated with medical laboratory. And what Bonini found back in 2002 is that even when different study designs, patient numbers, and discovery techniques were used, the distribution of errors across the different phases of the entire testing process was very similar. So no matter who is doing the study, the samples usually occurred in the same place. And that they found that regardless of the study, a large percentage of laboratory errors occurred in the pre- and post-analytical phases, with fewer mistakes in the analytical phase, so at the laboratory. So getting the samples to the lab and reporting the results afterwards, those are where the most errors occurred. And that's numbering problems, interpretation problems, etc. Another paper from 1997, types and frequencies of laboratory errors, especially in a stat laboratory. And I'll make a little sideline about stat results or rush results. I find if you want something done right, the best, the same way every time, don't push the system. So if a test is supposed to be run on Tuesday with results on Wednesday, that's going to be the best time to do it. And that's already been pre-decided by the laboratory. That said, we can rush a lot of results. We can take somebody off of running, I don't even know, brachyspira cultures. We can take that person off of brachyspira cultures and make them do salmonella cultures for one day because we have a lot of tests to get out for an export or something like that. But the best thing to do is let the laboratory do the best things at the best times. And so stat errors could occur because people are rushing around. And I'm at fault at this as well. If I have a rush sample, there's actually times where I deliver it to the laboratory. Well, then I get to the laboratory and there's nobody there. And so I put it in the wrong refrigerator and they never saw the result. Things can happen like that. So that's why stat results need to be analyzed separately, and that's why they did a separate paper on them. They had 40,000 stat results. They found an error rate of 0.47%, 189 errors in that stat result. 68% of those were pre-analytical, mislabeled samples, for example. 13% were analytical and 18% were post-analytical errors. So rush results happen because people take shortcuts. Here's 10 tubes, and they're not labeled. Or here's 10 tubes, but I only had purple tops, so that's the pre-analytical error there. Thought that was interesting as well. So reducing laboratory errors then is a shared responsibility. And as veterinarians, we should be able to carefully observe and describe diseases. That's part of our training. We correlate the history, the physical exams, clinical science, and production data together. That's an essential skill all veterinarians should have. This is what makes taking all those small animal medicine classes worthwhile, is because you were taught to soap, and it's useful for food animal production as well. You should know when and how and what type of sample to take and what extent of lab investigations to undertake. You should be able to understand and interpret the significance of the laboratory results obtained. You should use knowledge of pathological principles to formulate possible differential diagnoses. You should be able to develop hypotheses about underlying mechanisms of disease. And you should be able to explain the basic mechanisms underlying the disease. Why does a 3-day-old piglet, more often die from diarrhea than a 3-week-old piglet? Right? Because 3-day-old piglets dehydrate more quickly than 3-week-old piglets. Is the only source of fluid intake for a 3-day-old piglet is a sow, whereas a 3-week-old piglet might have access to water as well. And the other thing about regeneration of the villi and things like that. So here's some good stuff. This is an example of a proper disease investigation. This is something that happened just recently. The clinical signs were increased coughing. And so what were they going to do about that? Yeah, let's see if the cough goes away. Well, no, this is a herd that's not supposed to cough. It's supposed to be a high health herd. So they were planning to visit the farm, collect samples, submit to the labs, get results, and make decisions. And they wanted to do this right away. Rush is the word that we often use, but this was very urgent. Movement to another farm was going to happen as soon as possible based on these decisions. And so they had some options here. They could drive the samples to the nearest laboratory, or they could do morning delivery by a courier, FedEx. They chose to do morning delivery by FedEx and alert the lab to this samples coming in. Because we want to be able to know that we're going to look for this box from your farm. If you tell us it's coming FedEx, morning delivery, one, it should come separate from the other samples, but if it doesn't, we want to look for your box from your farm. And we can know your clinic name, your farm name, or whatever. And we're going to look for that box out of that stock and process that one first. There's him processing it. Both these guys are veterinarians now. The other way to do a proper disease investigation, what they did on this one is they prioritized their differentials, and they worked with the laboratory to decide what tests to do first and what samples were needed to do those tests as rapidly as possible. So you have to decide which diseases are most important for you to rule out or rule in. So certainly in a high health herd that has never coughed before, they wanted to rule out PRRS and mycoplasma immediately, right? Haemophilus pursuis, Bordetella, Pasteurella, yay, we got those diagnoses, but that's not something that needs to be done immediately because those pathogens are probably in the pigs regardless. So which tests can be done? We can do an ELISA, we can do a PCR. What tests can be done rapidly? Well, there's antigen detection tests out there. A lot of people call these point of care tests or SNAP tests. They can be done in 15 minutes. You can have these kits on farm, but they have a much decreased sensitivity than a PCR, for example. So you could have an on-farm diagnosis, or as soon as the sample gets to a lab, we could have a test done in as soon as 15 minutes if we use an antigen capture test, like a SNAP test. But it has a low sensitivity, and so it might be falsely negative. PCR tests now, a lot of our PCR tests are real-time, especially for the pathogens of importance to pigs, such as PRRS, Mycoplasma, influenza, TG, PD. And those are real-time tests, and so those can be done in approximately 4 hours, but the specimen type will affect the processing time, which will delay the results. And there is cases where people have actually watched the real-time PCR run to see when the sample reaches the threshold, and they will call sample positive within 2 hours or 1 hour if they're watching it. Kind of risky to do, but it is possible to have a very rapid diagnosis. And then there's virus isolation. It requires virus and proper cell type, and it can take days. Certainly influenza, an acutely affected pig, would grow on the proper cell type within 12 to 24 hours, but usually we don't have the cell type ready for that sample at that time, and so it's going to be days for a diagnosis versus PCR or antigen capture. Talking about serology tests that can be done rapidly, most ELISA tests take 2 to 4 hours, and they detect antibodies, so exposure to the pathogen of concern must have already occurred. So if you have an acute outbreak, you may be within that 2-week seroconversion time or 5 to 10 day seroconversion time. You might have a false negative by ELISA if antibodies have not been formed yet. Know that other tests like SN, serum neutralization, IFA, indirect fluorescent antibody, or HI, hemagglutination inhibition, those usually take 12 hours or more because there's an interaction of virus and serum that must occur. Some types it's and with SN, it's in cells. And usually these detect specific strains or antibodies to specific strains, so they can lead to false negatives. Plus they're slow. So back to our proper disease investigation. What we had was respiratory disease and replacement gilts at the farm of origin, and they alerted the lab to rush these samples upon receipt, and here was their prioritized disease differentials. Herd was previously negative for PRRS, mycoplasma, and influenza. Well, influenza, it comes and goes, right? But they wanted these 3 things ruled out as quickly as possible. And so this is what happened and what we did. They communicated us in advance, so we knew they were having coughing and nasal discharge with 5% of the pigs sick from a herd of 1,800, or a group of 1,800. And this is what they submitted, nasal swabs, and they recorded temperatures and IDs on these animals as well. And then fixed and unfixed tissues. And a nice thing, they did coughing pig tissues and a pig with no clinical signs. And I'll give them, this might be an overinterpretation or a laboratory error on my part, an analytical error. They actually didn't write the word clinical signs, they wrote CS, no CS. So I assumed that it was clinical signs. That could have been an error, but it turned out not to be. No gross lesions. They opened up these pigs, reported no gross lesions, even though there was coughing in the one pig. So no lesions. But on histopathology, that coughing pig had characteristic lesions of mycoplasma high pneumonia with all the hallmarks and descriptions of the disease possible: peribronchitis, perivasculitis, edema, neutrophils, bronchopneumonia, some bronchiolitis, no other lesions in the other tissues. And the pig with no clinical signs and no gross lesions had no microscopic lesions as well. If we look at individual diagnostic results, and we can take these one by one or whatever, the pigs with fevers, numbers 1 and number 2, we had nasal swabs. They were positive for mycoplasma and negative for influenza virus. The pigs without fevers, pigs 3, 4, and 5, all negative for mycoplasma and negative for influenza on that nasal swab PCR. What if they had only submitted nasal swabs? We would have a mycoplasma PCR and a nasal swab, but in this case, we actually had tissues to support that diagnostic. So we had characteristic lesions of mycoplasma in those tissues. We detected mycoplasma high pneumonia in that tissue and in a nasal swab from related pigs in the farm or nearby pigs in the farm, and we cultured pastoral maltacida as well. It also detected PCV2, but no lesions of PCAV in the tissue examined. And the pig with no clinical signs, the only thing we found in that pig was PCV2, a ubiquitous pathogen, but no lesions of PCVAD in that animal. And so we had a complete and proper disease investigation. Was it PRRS? No. Was it flu? No. Was it mycoplasma? Yes. And how do you know this with any confidence? In this case, we had histo, we had lesions, we had clinical signs, and we had detection of the pathogen all together to confirm the diagnosis. Devastating for the farm, good for the submitting veterinarian, and good for the laboratory. We got an answer for people. It wasn't the answer they probably want, but it was an answer that we have with confidence. What can we do later to confirm this? It's been about 2 weeks now. We could do serum antibodies on this unvaccinated herd to show probably antibody detection of mycoplasma as well. Here's an example of an incomplete, albeit useful and diagnostic disease investigation. And I usually present this as a case study called, Can You Diagnose Respiratory Disease Without Doing a Necropsy? So, can I keep my job? The answer is yes, I think. Let's go through this case. So this is emails. I just pasted these emails. It's kind of funny. But just telling me about a respiratory outbreak and 350 gilts that came into the sow farm 3 weeks ago. And the reason they sent this long email to me, that Bill sent this long email to me, is because he didn't have a history in the package. The package just said, lung tissue, here we go, or serum, here we go. Describing to me the vaccination history, the clinical signs, when the animals were moved in, what happened to them or in isolation, additional clinical signs like low feed intake, hard breathing, how many of them have that? This is a very detailed history. No wonder he didn't write it on the submission form, it would have took forever. It's just as easy to email it to the diagnostician. And we can print this out and make it part of the case, if you'd like. This is always nice to say what's in the package. 16 nasal swabs and sera for an initial exploration. He went to this farm, didn't do any necropsies. Why? Because there's none done today. Because there's no dead pigs. But we have 50% with decreased feed intake, 20% hard breathing, 3% with chronic respiratory disease. Could he have euthanized those 3 with chronic respiratory disease or the 20% with hard breathing? Certainly. But he didn't want to do that because that's expensive for the farm. What tests they'd like run, he'd still like to do nasal swabs for flu, possibly a mycoplasma, because he knows that nasal swabs for mycoplasma might not yield very good results. And any other things I would think. Serum, PRRS, ELISA positive because they're vaccinated for PRRS. But could they do PCR for exposure to an alternative strain of the vaccine? Could we do PCR for flu? And he's going to send in convalescent sera later. And of course, you know, I always reply, not always, but I always reply to emails. And sometimes I just say checking and will do, but I do reply to the emails. And here's my diagnostic plan. I've got to do flu PCR, 4 pools of 4 swabs each, myco PCR, 4 pools of 4 swabs each, and PRRS PCR, 4 pools of 4 sera each. And antibody testing for flu by a multi-screen ELISA detects antibodies to all type A influenza strains, because I don't know what type of flu these pigs have. The reason I'm pooling, I'm making that decision for the producer. This is and for the veterinarian. This is someone that didn't necropsy pigs because there's no deads. I'm assuming, maybe wrongly, that cost is an issue here, so I'm going to pool. And I do think screening for flu antibodies is good because if the flu antibody levels are strong, sampled in negative values of less than 0.3 for a competitive ELISA, I would suggest to me that these pigs were naturally exposed because usually the vaccines don't give those very strong responses as detected by the ELISA. And I promise to do my best. And sure enough, I've got some old names and dates on here, but these animals were strongly positive for influenza antibodies by the multi-screen ELISA. Very strong positives, less than 3 in a lot of the animals. 0.1s. We rarely see this with vaccine. This is almost always natural exposure with booster from a vaccine or straight natural exposure. And we've done hundreds and hundreds of these, and there's a published paper on this on the multi-screen ELISA, how antibodies to natural infection as detected by the flu ELISA are strongly positive or lower values. And then we started to do our samples. Here's all of our individual IDs, and we did the mycoplasma high pneumonia PCR test, and 3 of the pools were negative, but one of the pools was initially low positive, and now we have to wait for an individual test on these 4 samples of this pool here. That's what individual test means. That's not an answer. What does that mean? That's not negative or positive. Going back to the serum, PRRS negative on the serum, influenza negative on nasal swabs. So I reported all those results to him. Dear Marie needs some more helps. They've been vaccinated with flu. Are these titers reflective of vaccine? Yes or no? I would say they're not reflective of vaccine only. They're reflective of some natural exposure as well. PCR was negative. Is there any way I can figure out what type of flu these pigs were exposed to while they're vaccinated and naturally exposed? I don't know. We could do a lot more testing. Mycoplasma PCRs were negative. Did I miss it? Is nasal swab PCR for mycoplasma any good? He's asking me. Would serology have affected the PCR results? Lots and lots of questions here. Hey, this group has responded well to antibiotics in the water, suggesting mycoplasma is involved. What's the answer here? Sorry for the late reply. This is what kills me. June 9th to June 10th. Sorry I was so late in one day. Took a vacation day. That was my last one, June 10th. No, I'm just kidding. So my interpretation of this, flu ELISA results strong. It looks like they were naturally exposed to flu. I don't have any tissues to verify and tell you with 100% confidence that they're infected. Like the mycoplasma case, I'm confident those pigs have mycoplasma. I have tissues to look at as well. What I can tell you is that we usually see flu values less than 5 due to natural infection. Yes, we could tease out a lot of specific HI responses doing the different strains in their flu vaccine and some common field strains, but that would add to the cost of the test. And regarding the mycoplasma pneumonia PCR test, there is actually one pool that was testing individually, remember? And he just glanced over that because I gave him a weird result. I gave him a result that said individual test. That's not negative. That's not positive. What the heck does that mean? And why isn't it done? And I said the testing will be either done July or on Friday or Tuesday. And certainly if there was a rush on these results, we could do them a little bit faster. A caveat on mycoplasma PCR nasal swabs, they work very well on naive animals, and they detect shudders in a few weeks of infection, especially if there's clinical signs, which this group had: hard breathing, off feed, some chronic respiratory disease. So my vote is to definitely wait and see how these individual myco-PCR tests turn out before doing anything. And yes, I do think that mycoplasma titers were a good idea. If naturally infected, they'll have high ELISA values, usually greater than 0.2 on the IDEX ELISA. So at this time, I was having a difficult time distinguishing if the group of replacement gilts went through flu or myco. Maybe it is that they had both. So my final plan was definitely do mycoplasma IDEX ELISA testing. And given that if they were positive on that and not vaccinated against myco, it'd be suggestive that they are infected with mycoplasma. And they also had response to antibiotics, which is also suggestive of mycoplasma. Well, sure enough, the individual tests, 33, 34, 35, and 6 are part of that positive pool here. Pool number 44 at 33 through 36. Individual tests, look for those. They're up here. Positive 1 out of 4. And he gives me the blessing to do the mycoplasma serology. And lo and behold, there's that nice all positive titers, not really high, but not vaccinated yet, so will likely rise in 2 to 3 weeks. Did I go down there? And then I go, hi, it was mycoplasma. Nasal swab PCR was positive, seropositive in 12 of the 16. Good job on the submission. And one brings me to one of my favorite things that I say, and everybody's probably sick of, is that response to treatment is a diagnostic test. If you think you have a bacterial disease and your pigs respond to antibiotic therapy, okay, you could have that you coincidentally are on the natural recovery from a virus, but response to treatment is a good diagnostic test. So we had clinical signs, response to treatment, we had seroconversion, we had PCR detection. We were able to diagnose mycoplasma pneumoniae. And I would have never been able to give all this feedback to this person had they not shared with me the vaccine status, the clinical signs, when the gilts came in, things like that. And then he said, oh yeah, well wait a second, now it doesn't matter what the heck mycoplasma or flu have when we just blew with PRRS. Could it be that these gilts brought in the PRRS? If you still have the sero, do that. And I said, yo, we did that. Back in June, that was one of your differentials. They were all negative back in then. So I don't know where the PRRS came in, but on the 16 gilts that you sampled, those 16 weren't actively with PRRS. I don't know how big the gilt introduction group was, but those 16 didn't have evidence of PRRS at that time. That's all I can say. Those 16 samples were negative on pools of 4. So can you actually diagnose respiratory disease without necropsy? Yes, if you're thoughtful and you're thorough and you communicate with the diagnostician so we know to interpret vaccine versus natural exposure and that we share things like response to clinical signs. All right, 10 minutes to, and so I'm already at my conclusions because I'm used to lecturing. When you give a lecture at vet school, it ends at 10 minutes to the hour. That does not go to noon, so we're going to end in 1 minute here. Conclusions, pig sample selection is very, very important. My boss, Dr. Jim Collins, says, yes, I can diagnose that disease, I just need the right pig. So he needs one pig, but it has to be the right pig. So whenever anybody asks about sample selection and how many pigs we need, his answer is one, but it has to be the right one. Mine is do some proper sample selection. Sample handling is very important. Information sharing is very important. Find a courier that's reliable. Find someone in the laboratory and a backup at your clinic that can package specimens the right way. Good information and good diagnostics are worth the investment. You can control devastating diseases such as mycoplasma, influenza, PRRS, TG, PED in your herd if you do a proper diagnosis.